We've developed a vaccine platform where we take a patient's tumor cell and we fuse it or create a hybridoma with their own dendritic cells. So we now have a powerful immune stimulating cell or educating cell, the dendritic cell, that is presenting the whole array of antigens from the patient's own tumor. And we think this is critical in generating a broad response and one that captures the individual antigens that are unique to that patient's tumor, what we call neoantigens that arise from their mutations. Now, this response in leukemia, for instance, was extremely effective in generating both leukemia-specific T cells in the circulation, and in a phase 2 study that we published, we saw that over 70% of patients remained in remission at 5 years of follow-up in a cohort of patients that were older, and typically you expect a much lower number than that. So that was very exciting, and we're now tackling that in a large randomized trial. But it also raised the question about what can we do to make the responses persist. How do we understand those patients that do relapse versus those who don't? And we've been exploring the role of immune modulation and the microenvironment to see whether we can make the responses better. So there was some exciting data coming from our group looking at hypomethylating agents, which are part of the standard armamentarium of how we take care of patients with acute leukemia, and showing that it actually alters antigen presentation. It makes the vaccine somewhat more potent, and in preclinical models and in murine model, there was enhanced efficacy of the vaccine when it was combined with a hypomethylating agent. We now have a study of our vaccine after allogeneic transplantation, where one of the two treatment arms is going to be the vaccine given in conjunction with a hypomethylating agent, decitabine. So we're excited to see what that shows us.